This is, yes, the vagus nerve. Okay, so we'll start off and talk about the case that everybody has been talking about recently. So how many of you guys are familiar with the Vandy nurse who was just criminally convicted? Raise your hands. Everybody. Okay, good. So this nurse, just to kind of recap what happened, was taking a patient down for imaging, had a patient in imaging. I don't even know if it was CT or MRI. Went to pull a sedative out of their automated dispensing cabinet, and she was going to pull Versed. And then she typed in VE into that cabinet, and vecuronium came up. Okay, and she didn't realize it and proceeded to pull vecuronium and administer vecuronium instead of Versed. Okay, when the patient got done with the scan, they realized that she was not alive anymore. And so this happened in December of 2017. It's again resurfacing. I think we all heard about this a few years ago when it happened, but resurfacing now because now she's being criminally convicted. I know there's been a lot of talk about, well, if they can criminally convict her, what does that mean for me? And I just want to tell you guys that this is not the first time that a healthcare provider has been criminally convicted for a medication error. So we'll talk about another case that happened about 10 years ago or so, in which a pharmacist was criminally convicted for an error. So we'll discuss that. But again, it kind of brings to light, well, shoot, what could happen to me during work? So I could think the most important thing when we're talking about these errors and when we review errors, and we do this on a daily basis when we review eSafe events, is to not focus on, oh, how could that nurse have not known that the vecuronium had to be reconstituted and it was this volume instead of this volume and it said warning paralyzing agent all over it. Okay, we can talk about that all day long, but that doesn't really make a difference. What makes a difference is how have we assessed safety events like that and systematically assessed what our process is and what safeguards we have in place to prevent this kind of error from happening again. So it's not focusing on the person that made the mistake. How can we do better as a system to really help mitigate that risk moving forward? Because we don't want this to happen again. Dr. Hyde?
I think also just to echo, just because these criminal convictions can't happen doesn't mean that we agree with them or that they should happen. And in so many ways, they run completely opposite to a culture of safety, which supports and promotes reporting of errors to prevent future issues. And so we as an institution don't support this, by and large, with the exception of a very small number of cases where there was malice, the vast majority of errors are really the responsibility of the system, not the individual. And so the purpose of that safety and a lot of the other committees we have in place are really to make sure that our system is working as well as possible, not put anybody in the back.
Yeah, and we're going to get mics to pass around. Thank you. Okay, so what went wrong in this case? From what you guys have heard, what kind of things? Now, none of us were there and none of us know exactly what happened, right? I've heard reports from a pharmacist that was working there at the time that they had actually recently converted to Epic and there was not a communication between Epic and Omnicell or whatever ADC they were using at the time. So, but just in general, think about that process. What kinds of things from a system error and a person?
She was only able to type in VE and get her medicine.
Okay, I'm gonna have the mics passed around so the people on Zoom can hear you.
She was only able to type in VE and have drugs dispensed to her.
Okay. And she was using Versed, which is the brand name and not the generic name, right?
There wasn't a dual sign-off.
Okay, there wasn't a dual sign-off. Okay, so for high-risk meds, we have a safety stop in place requiring 2 nurses to sign off that a drug is being administered where they're supposed to be checking the 5 rights, right?
There wasn't a message that it was a paralyzing agent when she pulled it out.
He said there wasn't a message that there was a paralyzing agent. Sorry for Zoom people.
Yep, so an extra alert saying, this is what you're pulling out. Are you sure this is what you want to pull out?
She was also not on her home unit and had a trainee.
Okay. So in an unfamiliar area, maybe extra distraction. She's got somebody else that she's trying to train, so she's in a hurry.
Was there something on the label? I mean, on the cap?
Yeah, all of the paralytics have that pre-printed on there. It's not removable. But that is an extra safety feature that the industry has added. Yep. Okay, wasn't being monitored. So are you going to give Versed and then shove somebody into a scanner for 15 minutes?
No.
No.
If you guys can raise your hands when you say something so that we can put you on the mic for the Zoom.
Okay, good. So these are some of the things that I've kind of come up with. ADC safety features. So again, like Christy said, requiring more than 2 letters when you're searching a drug. What about override culture? Do we have an override culture here at Erlanger? You bet we do. Yeah, we do. And that is, I'm going to pick on the physicians for a minute. That's as much physician driven as it is nursing driven. Alert fatigue. I've read somewhere that she actually bypassed 5 alerts. I don't know if that was true or not. I wasn't there, but I did read that she bypassed 5 different alerts. Do you guys get 500 alerts every time you do something? Because I know I do. Okay. Monitoring requirements. So what was their policy on monitoring requirements, and was it being followed? Okay. Availability of barcode scanning in non-patient care areas. Again, I'm not sure exactly what the process looked like in their area. If you don't have an order for something, barcode scanning doesn't really help you all that much because it's not comparing. What about reporting culture? Who reported this event? Was it Vanderbilt? She did. That's a huge problem. So as you can see, there's a lot of system failures that we can identify and just a few actual individual person failures. So she overrode a bunch of warnings, okay? She failed to verify the 5 rights, the right medication. Was she familiar with the medication that she was giving? I don't know. I don't know how often she would administer Versed, but I know after, talking to a bunch of nurses, a nurse probably would not give Versed without continuing to monitor their patient, right? What about this? Is that an urgent or an emergent medication that she's administering? Just because the CT scanner people want you to hurry up because they've got a bunch of people they need to get through doesn't make that an emergency at all, okay? And so I think that a lot of errors will come back to that point. Identifying whether something is truly an emergency, that patient is going to die if they don't have the medication right now, versus whether it's urgent, you're in a hurry, okay? And I would really encourage you guys to drive home that point with your nursing staff, because it's a risk for everybody involved in caring for that patient.
And also, what is urgent versus I just need to do this now? Again, making sure that we understand the true definitions of emergency versus a true urgency versus somebody's telling me I need to hurry.
And I would like to speak from all 4 of us, I guess, in this row, is that we're, as nursing leaders, support you guys to stand up to the physicians and say that we're not taking verbal orders, we're not taking stat orders, we're not overriding things if it's not a true emergency. And so you will never get put in a spot where if you do say, no, I need you to put that order in, that we're gonna not support you in that. We really want to stand behind this, that we want the physicians to put orders in.
Yeah, and I think if nursing staff gets pushback or any kind of inappropriate behavior from a physician in that type of situation, I do recommend entering that in eSafe. Sometimes I know people think, oh, nothing ever happens, but I can assure you that Jackie right here, has got it. Okay. Yes, she is a huge help and will really kind of put them to the fire if that needs to happen. So you got to protect yourself. So what have we done since all of this? So we have optimized our ADC safety features, so our Omnicell. Now, I don't know how many of you have pulled a paralytic within the last maybe 2 years. I think we did this. But when you remove a paralytic, you get this warning message that says, you're trying to remove a neuromuscular blocker. Is it intended to paralyze the patient? Have you considered an airway and sedation? Okay. And you have to say yes or no. And if you say yes, you have to confirm that you have made the correct response. Okay. In the Omnicell now, you can no longer search a drug without 5 letters, which can be a headache because some of those drugs are very difficult to spell. And I am saying that from a pharmacist who spent 6 years in school. Okay. I get it. But that requirement is directly from this patient case. Okay. The Institute for Safe Medication Practices, which is the organization that we use to help really do internal risk assessments. And a lot of our medication safety initiatives come from them. They actually, in their July to September quarterly action agenda, recommended changing your Omnicell upgrade so that you would require a 5-letter search, again, directly from this. And this organization takes patient cases like this, safety events, from all over the nation and does kind of an overall risk assessment and says, what can we do to operationally decrease this from happening everywhere? And so it's really important that we take the information that they put out and work really hard to implement at our own institution. Yes.
And also a reminder to everybody that if you're using an order, you don't have to worry about the 5-character search because you're actually going to pull up your patient to find the drug that you want to administer. So then you don't really have to be able to spell the drug. So it's all the more reason to be focused on the orders when you can be so that you don't run into that problem.
A lot of you have been here for a while and we're here in the days of nursing super users. So these were nursing users that were able to override any medication from the Omnicell, okay? They were given special access to ensure that the nursing staff on that unit had access to any drug in case of an emergency, okay? Well, what happened was all the CSLs, all the charge nurses, all the nurse managers were super users because they could all be there at some point when they didn't have someone else. And nurses that came out of those positions never got taken off of that super user list. Those nurses, nursing super users, were put in uncomfortable situations where maybe they didn't think that something should be overridden, but they were getting pressure from their peers to pull something for them. So it put nursing in an awkward situation. So we have since, with the blessing and wonderful help of Christy and Sarah, completely removed nursing super users. I know. No, y'all have been integral in these next couple things. So we don't no longer have nursing super users. We went through a list of God knows how many drugs and determined what drugs we felt like really could truly be needed in an emergency situation. And so we decreased that override drug list from over 350 drugs to about 100 drugs. I think we probably still have some work to do as we continue to monitor overrides, but this was a significant culture change for us. And, we continue to get pushback about this, but we've really been supported by nursing leadership and pharmacy leadership to really try to maintain this list. Did you have something to say? No? Okay. This is also, again, a recommendation from ISMP Hospital Best Practices and is actually in the CMS Conditions of Participation, which Eileen recently shared with me so I could see. So I used that. We've also segregated paralytic storage in the Omnicels. So vecuronium is in a locked box, okay, because that's not refrigerated. So it's just like a narcotic where you would have to open that specific box. You couldn't accidentally grab out of a whole tray of open drugs in the Omnicell. And then the paralytics that are in the refrigerator are in a plastic box with paralyzing agent stickers all over the box. So you have to intentionally go to that box and open it. If that is not the case in any of your nursing units, please let us know. We have done continual assessments to make sure that that's maintained. But please let us know if that's never the case, if that's not the case in your area. And again, this is one of the ISMP hospital best practices. So those are all the things we've done, but I think we still have a lot of opportunities, right? So the monitoring of medication overrides. I know we've been talking about this, it seems like forever since we've updated our override list at Med Safety. But are we monitoring what medications are being overridden? Are we assessing whether those should have been overridden? Was it an emergency or an urgency? Are there certain medications that are constantly overridden that we need to look at our process and say, do we need to put this in an order set somewhere so we have somebody that verifies that order and it's available to the nurse? We can utilize barcode MedAdmin scanning, non-compliance for real-time follow-up, education. We can decrease our list of medications that are on override further. We need to ditch the override culture. And I think we've started to do that, but I think this case coming to light has really, I think, given nursing the power to stand up and say, no, I'm not going to do that. Okay. We need to probably continue to assess areas that have phase of care problems where medications are released in inappropriate phases of care. So that's a continued work in process. Are Omnicells available everywhere they're needed? Okay, do we need to, a common practice that I see is, patients going down to the CT scanner. So I'm going to pull the drug from trauma ICU and I'm going to bring it with me down to the CT scanner. What about having the drugs that would be needed available in that CT Omnicell for those circumstances? Are scanners available in all areas? In MRI, in CT, in specials? Doesn't really matter if we don't have an order to scan it against. Okay. And then evaluation of our procedural Omnicell cabinets, making sure that the ones that are set up as procedural, where you can just remove everything, are appropriate. So we have been, a lot of you that attend Med Safety have known that we've been trying to get an Omnicell an Omnicell override report from Epic. And while that's continued to be worked on, the Omnicell software will generate an override report for each specific Omnicell. And so we're going to utilize this report until we can get an Epic report. Katie, do you want to speak to frequency and how we're going to set this up?
The purpose of this is many of you are probably familiar with the cycle count reports that come out on Fridays and Tuesdays, I think it is. So long story short is what we would like is, number one, we would like feedback from the group as to the frequency for these reports to be sent out. Because again, we don't want you to get a report that has 5,000 overrides that you're trying to sort through. If you get them more frequently, then you can follow up in real time. The purpose of the report, though, is that for each area, so for example, if you work in CVICU, you would only get the override report for CVICU on the designated day that we determine. And you would be able to look at it and say, okay, well, it looks like in this situation, the user's name is blacked out, but for you, it would not be. So you would know that in every single instance in CVICU, Bree Carter was the one that overrode all of these medications. Why is Bree always overriding medications, but Jessica Appleby is never overriding medications, right? So that you can try to hone in on what exactly is the problem. Why is every nurse in CVICU always overriding calcium chloride Abigex, right? So that you can really start to look for trends so that we can work on these. Because again, if we don't do it as a group, it's going to be very challenging to, as Bree put in the slide, ditch the override culture, right? And there are still many things that we're overriding out of convenience as opposed to for true need. So the goal would be for, based on the algorithm that we receive for who needs to get the report, that it would go out, maybe it's once a week, to the respective nurse leader, and they would be able to go through this report. And then the first time it comes out, they may not meet with anybody because they're going to be looking for trends, but then being able to follow up with those individuals and try to figure out where the problems are. And then we can bring it back to med safety. What trends are we seeing across the system? What seem to be very location specific, so that we can do something actionable with the information. And when I say actionable, I mean, how do we need to further fix the process? Is it education? Is it that the Omnicell's not working like it should? Is it that they don't have scanners? What exactly is the problem that we're running into?
Anybody have questions about this report or feedback as to how frequent nursing would find this useful, helpful? I know you guys have 500 million reports you look at.
Is this the only way to report it out? Like, would it be more helpful to y'all if they did it by med or by individual? Or is this the only way it reads?
I think Omnicell is kind of limited in reporting capability. Again, we're still trying to get with Epic to get something that's a little bit more user friendly that we can filter. And honestly, just looking at the meds that are overridden is one piece of that puzzle. We also need to make sure that the nurses that are overriding and administering these meds have an actual order to do so, because they're having to override it because it's not ordered. So what do you think your liability is if you go and give 100 mics of fentanyl and something happens to the patient, but you never had a physician order? Do you think the doctor's going to jump in and say, oh yeah, no, I told him to give it? No, that's a huge liability. It's a huge liability. So the Epic is able to find and pull the information when the override is linked to a physician order. And that's the other piece of this puzzle, is we need to make sure that our nurses are protecting themselves and that they actually have orders for what they're giving.
And this is truly a starting place, y'all, because as Bree mentioned, we're working with Epic to get a report that will help us tie in the pieces. But I think really and truly what we discussed was that we want to start somewhere. And if we just keep talking about we're going to have something to monitor it, but then we continue to not really have anything, at least this gives you some idea, where are our problem areas? What do we need to focus on so that we can start trying to figure out what's going on and why this is happening. And are you going to talk about the BCMA scanning report by chance in Epic, or?
No, I know they all. Go
Well,
ahead.
I was just going to, because for example, there's currently a BCMA scanning report that is available in Epic. And the nice thing about this is it will be auto-generated to your email. The other, you're going to have to go in and look for it and try to find it. And a good example there, and something that probably needs reiteration to our nursing staff, is that oftentimes what we see with the BCMA report is that we are overriding the warnings that we're getting when we actually do scan. So it may not even be tied to the meds overridden, but the scan itself is overridden. So for example, I go to scan my calcium chloride, I have an order for it, but it tells me that this medication's been discontinued. And instead of saying, okay, well, should I give it? Should I not give it? Why was it discontinued? I automatically pick that the barcode wasn't readable, when really that wasn't the reason that it gave me a warning. And all of that information is in Epic too, but we have a tendency to pick that one because it's the first option. And so really honing in again, we go back to, why am I getting a warning? What did the warning say? Did the warning tell me that this is the wrong med? And focusing on the warning. So I think that it's very much, we've got to know why we have the reports available and what to do with the report so that we can really make the best use of them, if that makes sense to everybody. But that's another area that leads to med errors as well.
Yeah, and I know we report out our BCMA scanning compliance at every med safety committee, and our goal is over 95%. So there's 5% of the time where we're not doing that, but that equates to upwards of 35,000 administrations. So think of the risk with that. And 5% doesn't seem like a lot. And awesome, we're meeting our goal 95% of the time, but you have to think about that other 5% of the time. How many administrations is that? Because that's a ton of risk. Yes.
We think that once a week on Tuesdays would be perfect.
Weekly on Tuesdays. Okay, we'll move on to the next case.
Can I ask one question about that
Yes.
really quick? So the thought was that after this, we would also bring that to clinical effectiveness, talk about it, remind, show everybody, and then implement it maybe at the 1st of May. Okay.
Okay, this was the next headline. Knoxville Hospital uses COVID as a liability shield for suit over fatal medical mistake. How many of you guys have heard about this case? Okay, I know this has been going around in email as well. So I'm not really going to talk about the COVID liability shield. And I really want to talk more about the medication error that occurred. This again was in Tennessee. So I need a volunteer, preferably someone that's not a nurse or not recently practiced as a nurse. Jackie, you want to go? Yeah, we'll bring one up here just in case. Okay, so Jackie is our nurse, and she is taking care of an intubated patient who had a subarachnoid hemorrhage, who is now being prescribed nimodipine because they're at risk of having vasospasm. Okay, and the doctor has ordered nimodipine 60 milligrams via the NG tube every 4 hours. And I'm Bree, the pharmacist, and I've sent Jackie up a nimodipine capsule and said, here you go, Jackie, give this to your nurse, or give this to your patient.
Okay.
Nurse Jackie. That's a show.
Wow.
Sorry. Just clicked. So Jackie has a nimodipine capsule here that obviously cannot go down an NG tube, right? So she has selected what she's got available in her unit, which is an IV syringe with a needle. Don't poke yourself. She is going to extract the contents of that capsule. Mm-hmm. You have an extra 15 minutes a day to do this, don't you? Every 4 hours? So Jackie's getting a little bit of liquid out of this capsule.
got the-
Okay, she's got some liquid in there. Okay. All right, Jackie, go ahead and give that.
I can't give it.
And that little ring on there. You got the.
There we go. Okay. This is gonna hurt.
Where did Jackie just give that? Nimodipine, the IV. Where was she supposed to give it? The NG. Could you have hooked this syringe up to this NG tube? No. Maybe. You probably would lose some in the sides. All right, thanks.
Thank you. I just stabbed myself.
So in 2010, the FDA issued a safety warning after 31 medication errors had been associated with the use of nimodipine. These are errors that had made it to the FDA. Okay, do we report all of our errors to the FDA? No. Okay, so 31 errors made it to the FDA. 25 of those errors were related to the wrong route of administration. Those errors resulted in 4 deaths, 5 near deaths, and 1 patient suffering permanent harm. Okay. So I'm going to go back real quick and talk about this case that happened up in Knoxville. The nurse had to crush a medication. I think it was a blood pressure medication, and had to give that medication via the patient's NG tube. And instead of giving it via the NG tube, they gave it through the IV, and the patient died fairly suddenly after administration due to the particles that were administered intravenously. So again, another wrong route, an oral medication being given via an IV instead of through the NG tube. So I've used this nimodipine demonstration because I really want us to think about, are we setting the nurse up for success by making them do this? No, you're almost asking them to give it IV, right? When I came here in 2015, this was what they were doing up on the floor. So this could have easily happened at Erlanger, okay? I think there was a case back 2006 to 8-ish where Carafate, I think, was administered intravenously here. Okay, so this happens. We cannot think that we would never do this, because this can happen anywhere, okay? So we really need to think about, how are we setting our system up? How are we setting our end users up to be successful and to decrease their risk? I would not blame a nurse at all if she accidentally gave this IV, because I've essentially given her an IV syringe that's only going to connect to an IV, okay? So what went wrong in both of these cases from a system?
The drug that was supposed to be given wasn't made in the best way to be given the route we wanted it to be given.
Yeah, we didn't provide it in the best available dose or form to be given by the nurse. What else? The syringe matched the IV tubing. Okay, so what supplies do we have available to our nurses? I was up in trauma, and I was just looking around. Well, the only oral syringes we have are these big 50 cc ones, right? Well, what if I have Carafate and I don't need to give the whole cup? How does a nurse measure that volume? Does she use an IV syringe so she can draw up the volume? So do we need to make these available to our nurses? These are our oral syringes. They say for oral use only. They don't connect to IVs. Okay.
Is there a way for the system to know if something needs to go NG, that syringe comes with the medicine? You know, when we give certain things, the tubing comes with the medicine, or the filter.
Yeah.
Does that make sense what I'm
Yeah, I
asking?
know what you're asking. I think if it's something that has to be drawn up out of a stock bottle, it comes from pharmacy in an oral syringe, okay? But if it is something that's in a unit dose cup, those are stocked in your Omnicell.
We can make oral syringes available. I think that the other issue that we run into sometimes is that pharmacy doesn't always know when your patient has an NG tube. And sometimes we're giving oral solutions because the patient can take oral things, they just can't swallow a tablet. So pharmacy doesn't always know the circumstance of the patient.
They just need to be stopped in
The oral
Yeah.
syringes do.
Yeah.
So here's my question, coming from being the person that ordered it in the ED, because I saw an ED with kids and we had liquid Tylenol. That was part of my supply stash. Does everybody know that needs to be part of the supply stash?
I don't think it's ever been on the adult side med surge, and that's what I just said. It just has to now become part of that. It needs to be a part of their supply, their floor stock.
Like a long time ago, like when we first got those syringes, was because it came out as a medication error because people were doing that.
I've never seen these up on the adult nursing units.
I mean, I
in
have
the-
actually
in the med
called the
rooms.
pharmacy on the night shift and been like, can you send me one of the baby syringes?
Yep.
And also, is there a supply issue?
There has been at times, and I'm sure that that's contributed to why they've not been as widely available. But I think that that's something that it's worth looking into. And if it's not currently a supply issue, to make sure that we have them and make sure that that communication is.
Yeah. Again, this is just, an area where we're thinking, okay, do we have what the nurses need to set them up for success? Reporting culture. I failed to mention when I was talking about this trial was that the nurse administered the drug and then she went back into her documentation and tried to document as not administered. So she's trying to cover it up and hide it, and she misled the medical examiner. So there was a whole series of things that transpired. But reporting culture, are nurses afraid to report when they make an error? Okay. If you're afraid to report errors like this, does me in pharmacy know what the nurse is doing up on the floor? No. We can very easily make this, come up with a solution for this, but if I don't ever hear about the problem, I'm never going to be able to help you. Again, from a people perspective, she failed to verify the 5 rights, used an IV syringe for an oral medication. So what have we done here? Our oral liquids that are sent from pharmacy that need to come from a stock bottle are in an oral use only syringe. It won't connect to these syringes won't connect to the IV tubing or the neuraxial tubing. Nimodipine is now provided in a syringe, oral syringe from pharmacy. There's no more of this business going on up on the nursing floors. This again is a recommendation from the ISMP best practices. So opportunities, again, oral syringe availability in our nursing areas where they need to be. We have not implemented the NR Fit neuraxial connectors. This was a recommendation from ISMP back in 2020. And these are, all of our neuraxial catheters have the same lure lock as our IV. Okay, so if you've got an epidural and you've got somebody with an IV, that epidural medication can be given intravenously and vice versa. So this is a huge, huge risk in an area that really does need to be addressed here. We need to make it a priority. If we can get the NR Fit, which would mean that there is only the neuraxial drugs would only connect to the neuraxial catheters. So this is an area that we really need to focus on.
And although I know that education only does so much, but a reminder to our nursing staff too, that there's not ever going to be anything provided for IV administration in a pill form at the cabinet level. We've also had a mistake before where hydrocodone liquid was pulled up into a syringe and given IV, and that nothing is going to be provided. Like if it needs IV administration, it's either going to come in a bag that's going to be hung on a pump, or it would be in a vial or a single administration syringe. So just using that as a reminder to everybody, because we can prep things, but we also have to make sure that there's no confusion in that regard too.
Okay, and I don't want this to all be picking on nursing, because guess what? Pharmacists make huge fatal errors as well. And so I also want to share this case where a pharmacist was sentenced to time for a toddler's death that he was involved in this case. And this happened in February of 2006 in Cleveland, Ohio. So their pharmacy computer system was down at the time. And they were already backed up because of the computer system being down. A nurse had called down requesting chemotherapy emergently for this 2-year-old. This pharmacist was working short-staffed. There was a shortage of IV solution, like the base solution. So that had to be compounded before the chemotherapy could be put into a bag with this base solution. And the technician that compounded that base solution mixed 23.4% saline instead of 0.9%, which is normal saline. The patient's has had osmotic demyelination and died shortly after this case. So another demonstration. This can be a nurse. I have a volunteer. Come on, Jeff. Naren. This is Naren the pharmacist. And I'm Bree the technician. You sit at that table. Is this on? So I'm gonna do a little bit of explanation here and show you what you've got in front of you, but you're the pharmacist, I'm the technician, and I just made this medication. We're giving Alteplase, which you guys know is a thrombolytic and it's a high risk med, right? We overdose it, somebody can bleed to death. So we have Alteplase here, and this is going to be going into a sheath that they have just done a thrombolysis procedure on, okay? So the Alteplase, you may or may not know this, comes in a vial, it's powder, and it has to be reconstituted, right? So this is, you know, that Alteplase comes like this, and that the technician, has to dilute that back in the IV room before I can mix it, okay? And so I have diluted it back here in my IV room, and I have added the drug to this bag of saline and said, okay, Naren, this is ready to check, okay? So I've got mixing instructions that say remove 50 cc's of saline from your bag, your IV bag. So this is my 50 cc syringe of saline. And I want you to add 50 mils of Alteplase that's been reconstituted. And this is a 1 milligram per ml solution, okay? Do you trust me? Can you tell? Can't you tell? No?
Yeah, the particles, yeah, they're definitely in there.
Yeah, the particles are dissolved, so that must be diluted to 1 milligram per ml. And this is a syringe, no fluid in here, but this is a syringe I use, and this is how much volume I use to put in that bag of my Alteplase. And you put your initials on that and send it up to the floor.
I don't feel safe with that.
Well, the nurse needs it right now.
Oh, that's good for the nurse, but that seems like a accident waiting to happen.
Okay, so Naren has no idea, he's got no confirmation that this has been reconstituted appropriately, right? The technician says that this is how much medication they pulled up, but this is how we provide. This is what we provide to our pharmacists every day for pharmacists verifying drugs. This is our current practice. Seems great, doesn't it? No, we have a huge opportunity here, right? So there are systems in place, software systems in place, and I think Epic has this capability that we're currently investigating where Naren would have to take pictures of every step in his process. So he would have to take the solution, he'd have to take a picture of how much he drew up to reconstitute this. This would have to be checked and verified by a pharmacist before he could ever move on to step 2 of adding the drug to this bag. Okay. So we're working on implementing this, but I'm picking on pharmacy here because I don't want you to think that this is all nursing errors. This is real life today in Erlanger. how we function. And it's scary. So I think the important thing is we recognize where we have these risks and work to make this better. Okay, thanks, Naren.
I did so.
And so to tag on to what Bree said, two of the things that are available. So we actually have implemented cameras in the children's pharmacy so that they can use those for verification. We trialed them there to see how it rolled out so that we can implement them in the other IV compounding spaces. And something else that's available that we've looked into, it's called gravimetrics, where they can actually weigh what you're doing because it knows how much it's supposed to weigh so that you know whether or not it is what it's supposed to be. So that's a lot more complicated. But again, a pharmacist can't always be in the IV space with the technicians as they're compounding. And it can be scary as a pharmacist to send something because you're like, okay, I know you pulled this up to this mark, but how do I know that you actually did all these things? And I remember when I got out of pharmacy school, I graduated in 2007, and it was right after the situation occurred. And I remember I drove the technicians here. I was here crazy because I was like, I'm not checking this. I'm not checking this. And they're like, well, but why not? Everybody checks it.
Yeah.
I'm like, because there was a pharmacist and he just went to prison. So anyway, long story short, it does create, you want to be functional, but at the same time, it's scary and you're trying to make sure that you've got all those stop gaps in place. And sometimes it's not as pretty and succinct as you would like for it to be. So.
Yeah, so they call this the pullback method, and it doesn't work. No, really, this is what it's called. And it doesn't work. Would not recommend it. Sorry, I had to throw a little humor in there. So what went wrong in this case? We've kind of already talked about this. So we had, in this pharmacist case, they had unsafe working conditions. Their computer system was down. They were short-staffed. They were already behind. They didn't provide a standard recipe during a drug shortage. So drug shortages are huge setups for medication errors, huge setups. So when we're coming up with alternative plans and how we're going to manage this, that constantly needs to be in the back of your mind. You're providing a product that maybe isn't the same concentration. It looks different. Or maybe it looks the same, but it's a different concentration. So it's really important that we have a heightened awareness during those times. Again, the pullback method of checking IVs is not acceptable. We've got to do better. Training requirements for pharmacy technicians. This prompted in Ohio a mandatory kind of certification level for pharmacy technicians before they could work in the pharmacy. And do we need a second check for high-risk medications? They were mixing chemotherapy. It's a high-risk med, okay? Never mind the fact that the patient was a 2-year-old. So people-wise, unnecessary urgency for a non-emergent medication, okay? When is the last time you guys have given or heard of an emergent chemotherapy? Never, 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 okay? He was rushing to check the medication. Okay. So what have we done here? Chemotherapy requires 2 pharmacists to sign off on that mixture before it's sent out of the pharmacy. I don't know if any of you guys have seen the pharmacy setup, but the IV room is somewhat set up to help minimize distractions. So that pharmacist has their own workstation right by the IV room. And it's not right in the middle of all the other madness that's going on down there. We have recipes for IV preparations. So it has to be built into Epic when we make a new preparation available. And we do scan each component for IV compounds. So for a recipe, it says I have to use these drugs, and each of those have to be scanned in the IV room prior to administration. And Epic will alert you, and it will alert the pharmacist that's verifying if a warning was overridden. And then again, we're working on the camera implementation. Opportunities, our camera implementation. Again, this is one of our hospital best practices that as a med safety committee, we have been working to implement. So I just want to briefly talk about the Medication Safety Committee for those of you that are not aware of what this committee does. It was established in October of 2020, and we've really been focusing on implementing the ISMP best practices. Again, all of these recommendations are coming from reports that this safety organization has received. We're working on looking at corrective action plans for medication-related occurrences, reviewing from a system what we can be doing, and then have an internal review of medication occurrences. We also hired a med safety and drug diversion specialist in November of 2021. So she's fairly new here, but Ashley Williams, and this is her picture and this is her contact information, her email. If you guys ever have anything you notice that you think is unsafe, please bring it to the Med Safety Committee, bring it to Ashley's attention. She'll get it on the agenda and we can assess that and see what we can do from a system standpoint. Because if it's occurring here, it's probably occurring at our other hospitals too. And we can't just be, oh, I'm going to fix this on my unit. We need to fix it as a system. Let's see here. I also have, and I know this may be difficult for you guys to see, but we do have reporting capabilities in eSafe. And so I wanted to bring your attention to what our kind of current metrics are. And this is a rolling 12 months. So we've had in the last 12 months, 465 medication-related events reported. What do you guys think about that number? That's super low, super low. I don't have benchmarking data. We weren't able to pull anything from Press Ganey, but this is incredibly low. I don't imagine it's going to get much better with this criminal conviction of this nurse, but I think we really do need to encourage our staff to report these errors. And I also think that when you're reviewing an eSafe or you're doing something to follow up on or to fix a process on an eSafe, it would be extremely helpful if you went back to that individual who reported to let them know what actions are being taken. Because I think a lot of the thought is that I'll put these in and I never see anything change, and this, this continues to happen, and they can't sign in and see all of the commentary and the investigation and what kind of changes we've made. So I really think that follow-up back with our staff as to what we have done or what we're looking at doing, maybe seeing if they have any recommendations as to what we could change. They're the frontline user, they observed the error. And a lot of times they don't put in a ton of detail as to what led up to the error. So I really think that's important.
Also, to kind of piggyback off of that, and it's maybe an easier sell in some ways. I think this, oh yeah, thank you. Maybe an easier sell in some ways than actual events is the B level category, the near misses. We're really not good at reporting near misses, and that really should be like the area that's most ripe for intervention because nobody's gotten hurt yet. Nobody's gonna get in trouble. It's really, if we can ramp up where we're seeing those near misses, then we can potentially even prevent things from happening down the road. So really encouraging those events to get reported would be super helpful.
Yeah, that's a great point.
And even showing, as we already mentioned, what do we do with that near miss information? What process did we change to make sure that it doesn't happen again? And just for everybody's reference, just on the adult main campus alone, we will have dispensed, if we annualize where I think we will, just around 2.7 million doses in a 12-month period. So for 465 errors to be reported on 2.7 million doses, it gives you a little bit of perspective on how underreported things probably are.
This is just the data on the errors reported in a little bit different way, looking at what types of incidents. So for those of you who cannot read this extremely small print, delays were frequently reported, failure to monitor, extra dose or a duplication, medication was contraindicated. Most common was omission. So those of you that have eSafe access and report access, should be able, these are in the pharmacy reports, but you can actually hover down and drill into all of these errors. So we recently pulled data. Dia Perry helped me generate a report of heparin errors, and we had upwards of 40 heparin errors in like an 8-month time period. And so we pulled every one of them and tried to identify, group them into types of errors, and was there a common theme? So this is the kind of data that's really helpful to us and really helps us improve. But if nobody reports it, we're never going to be able to do it. And got one more here. And this again is another way to kind of separate out this information as to what went wrong. So most frequent errors here were wrong dose or strength, wrong administration technique, wrong medication or fluid, or wrong rate. Okay. So you guys can see what types of errors are being reported. But again, it's helpful to look at these trends and then to drill down and see, you know, are there certain drugs that we're administering at the wrong rate all the time? And is it because the instructions in Epic don't match the instructions in the IV pump? Is there some disconnect? Okay. All right. I'll leave that just in time. Do you guys have any questions or comments? Thanks.
And just as follow up to everybody, and I hope everybody knows this, but pharmacy is definitely here for a resource to all of your nursing staff. If you ever have questions, have issues, don't know why something is the way that it is, please don't ever hesitate to reach out. I mean, Bree showed the contact information for our new team member, but also Bree's available. Amanda's here today. She is our ops manager now. She's available. I'm always available. We really want it to be collaborative. And again, if we're not working together, we can't make it better for our patients. So please don't ever feel like we don't want to assist.
Yeah, Dr. Hyde is our physician champion. And so she's been really integral in helping us, you know, especially when we start to give some pushback on the overrides, it's going to be really helpful to have a physician advocate to help us with that. So there's a lot of other IS&P initiatives that we have been working on that I did not talk about in this presentation, but I really wanted to link some of the errors that have kind of been shared nationally with some of the initiatives that we have been undertaking.
Also to nursing, I would like to reach out and maybe have some representatives from the frontline staff to help us with the medication reporting page, maybe make it easier for them. I mean, what I see in DSC, we know we need, but what does nursing want? So they would report better. So please reach out. I don't know if that's part of your governance, maybe. It's in the budget. It's in the budget.
Are there any questions on the chat, John? Sorry, I don't have Zoom down here. Okay. All right. Well, thank you guys. I appreciate your participation.
Thank y'all. Thanks, Bree.
Yep. It's old.